your sub-internship rotations or audition rotations. This meeting will be recorded and later posted to the SAOAO Virtual Resource Center. So be on the lookout for further correspondence as we will be batch posting our previous talks there in the near future. In addition to this talk, we will be hosting another hard skills talk this upcoming Monday. That will be focused on high yield fracture classifications, which are also key to your future sub-I rotations. Without further ado, I'd like to introduce our presenter, Dr. Jamil Haddad, who is a first-year orthopedic surgery resident at McLaren Macomb. Dr. Haddad, would you like to introduce yourself?
Yeah, hey, my name is Dr. Jamal Haddad. I'm the orthopedic surgery resident. I'm an intern first year at McLaren Macomb. I know many of you through meeting some of you guys at the AOAO conference in Boston, and then some of you through Michigan State University Orthopedic Interest Group and various other endeavors as well. I really look forward to giving this talk and also inviting all of you to join my fracture conference. It is classically bi-weekly. Next one will be this upcoming Saturday. I'll send an email shortly with the email list and the sign up link here at the end if you guys would like to join. So yeah, without further ado, um, just if you could allow sharing so I could present my lecture here. Jeremy did a great job of putting together a splinting lecture, and thank you to Jermaine for reaching out to present this. Um, but so to start off, we're going to talk about the differences between casting and splinting. Essentially, nobody really knows that is not in the field of orthopedics. Oftentimes, I hear a splint referred to a cast and vice versa. A cast is a circumferentially applied immobilization technique used for essentially chronic injuries where swelling isn't of immediate concern. It does have increased risk of creating like an iatrogenic compartment syndrome, and it has various risks. And then a splint is something kind of applied more in a specific fashion, such as medial lateral or. Um, all right, perfect. So here's the screen sharing. Um, Here's the lecture. All right, perfect. So you guys can follow our McLaren Macomb orthopedic surgery page if you would like. It is at, I think, McLaren Macomb Ortho, something along those lines. But so to start off, we're going to start talk about splints. So splints are usually made from slabs of plaster or fiberglass. When it's used in a slab of fiberglass, it's usually pre-formed. It comes out in like these pre-rolled up sheets. It's called orthoglass. It's usually stuck between two sheets of cast padding already. That's like Velcro together at the end. So you open it up, you have fiberglass inside. Or classically, it's used of plasters. Plaster is pretty messy, but that is how we do it because it allows for really good kind of custom fitting around whatever joint that we are trying to approximate. But as you guys can see right here, a couple different types of splints. So right here on the upper left, that's a thumb spica splint, and then right here is just like a volar dorsal. It's called a sugar tongue splint. It's a very important immobilization for like the distal radius or like a distal both bone fracture where you're trying to immobilize supination and pronation. So it starts right at the metacarpal heads, both volarly and dorsally, which is always a little bit more proximal than where you think, because a lot of people put their splints right up to the MCP juncture, but if it gets right here, then you're not able to flex it, as you guys can see, because it would be too distal. So it's very important to go more proximal than you think, but not too proximal. You want to get to the level of the distal wrist crease, which always goes in like a descending fashion as the metacarpals get smaller over time. It's non-circumferential. That's a very important key characteristic to differentiate between splints and casts, in the sense that it doesn't circumferentiate or circle around a joint or whatever type of long bone, which is important because it allows for the tissues to breathe. It essentially decreases the risk for a compartment syndrome. In the pediatric management of kind of upper and lower extremity fractures, it's very important to immobilize in a good fashion so that you can at least prevent a surgery that's maybe unneeded. And the ways that we measure that is through something called non-operative tolerances, where we radiographically analyze the bones and we see essentially how displaced it is. And if it is too displaced, then essentially you'll need surgery. So getting a really good immobilization in a splint in the emergency department or a cast, depending on what technique you're using, is quintessential for uh, appropriate management and preventing people from getting unnecessary surgeries. It is non-circumferential. It's primarily used during the acute period after injury and later traded out for a cast in the clinic. With stable injuries, splints can be used as definitive treatment, particularly like if you have like do- an extra-articular dorsally angulated distal radius fracture with minimal comminution, which means the injury is dorsally angulated, so the articular surface of the distal radius is it pointing in the 22 degrees, sorry, the 11 degrees of volar inclination that it's supposed to be pointing, but it's rather dorsally angulated. So after you reduce it and you put the fracture in the appropriate position, um, then it can actually uh, be treated non-operatively without a surgery. But if it is too dorsally angulated, that leads to obviously a clear deformity in addition to limitations on range of motion and the like. So it's very important to put them on in an appropriate fashion. Um, but it does have less support than a cast, and it is better accommodating of tissue edema. Whereas a cast is wrapped circumferentially. I've had patients come to the emergency department because of casts, not put on by myself, but put on in clinic or various other providers that are is just way too tight. They're like really tensioning and pulling tension on the tissue while applying the fiberglass circumferentially, and they come back with severe swelling or pain, and I have to cut the cast off, evaluate the tissues. Sometimes it was just too tight and causing distal edema because you're cutting off the lymphatics and the circulation. And you can actually create a Volkmann's contracture in the forearm, which is like a contracture and a missed compartment syndrome, essentially, if you're just over sedating and or giving pain meds to these kids. And the number one kind of sign of compartment syndrome in pediatric patients is increasing needs for analgesia or pain control. So something to look out for on your boards and rotation. Um, but many splints are prefabricated medical devices with Velcro on a metal hinge, which can restrict movement in an undesired planes while allowing movement or degrees of range of motion in desired planes. So essentially, this is essentially like a volar wrist splint, oftentimes used for carpal tunnel, holding the wrist in about 30 to 40 degrees of wrist extension, which puts the median nerve at the carpal tunnel at rest, and it usually helps people like 90% of the time with carpal tunnel, so they don't need to progress to have surgery. But the different types of prefabricated splint options, you have static splints that just hold it position still. You have static progressive splints. Right here, this is called the elbow IROM, which is like an adjustable range of motion. That's called IROM, IROM. You have elbow IROMs, you have knee IROMs, and so on and so forth. And essentially, what it does is you can control how many degrees of extension and how many degrees of flexion. Like if you have an olecranon fracture, which is of the proximal ulna, that usually fails under tension because the olecranon just wants this spread apart. So usually when you splint them in extension because you don't want the bones pulling apart at the insertion of the triceps, the proximal olecranon. Otherwise, it will kind of pull apart and fail. Um, and so that's for like for example olecranon fractures. For most other type of elbow fractures, especially like supracondylar fractures in pediatric patients, or just distal humerus fractures, usually you can immobilize them in like 30 to 40 degrees of flexion or more, depending on your injury. And then you have dynamic splints, which allow patients to move the splinted body part within a certain range of motion, and you can adjust that range of motion as the patient improves. Very important, especially when fixing tendons, because like when you fix a flexor tendon of the finger, you repair it. Something very important for all of medical students to understand is essentially when you fix a tendon, like if you're fixing a flexor tendon, you don't want that tissue taut and really tense. Otherwise, it's going to retract and it's not going to heal well. So when you fix like the flexor side of the tendons, you're going to splint them in the emergency department, or even if you don't fix it, even if you just visualize it, because flexor tendons are never fixed in the emergency department. They're always fixed in the operating room for several reasons. Number one is you have neurovascular bundles that run just radial and ulnar to all of them. And if you damage those, that's no good. If you damage both ulnar and radial on any finger, then you're cutting off all blood supply to it and you're causing essentially a dead finger that's going to arise. So you have to do that intraoperatively under appropriate anesthesia and with appropriate like microscopic magnification, typically used through loops, which are like the little magnets, sorry, the little magnification lenses that they use to kind of visualize everything really well. And then extensor tendons are immobilized in extension to allow for them to be relaxed because you don't want it to be taut. Otherwise, it won't heal. It will retract. Bad things will happen. But whenever you do repair tendons, you immobilize them for a little bit, a couple weeks or so, sometimes up to 4 weeks, and then after that, you want them to start ranging it. But you want to limit that range of motion, so you do it through dynamic splints, and then serial splints. Like this is showing the picture of a lumifoam finger splint, which just holds the finger in a certain position. So the importance of splinting is immobilization essentially to prevent displacement, angulation, shortening, ensure proper positioning, pain relief, and prevent further damage. So the most important thing here to consider is whenever you splint a different body part, there's different non-operative parameters that we measure radiographically and clinically to assess how this patient is going to do with non-operative treatment. In other words, if this fracture were to heal exactly where it is right now in this splint or this cast, how is the patient going to do? Essentially, if the fingers, as I flex the fingers, all of four of my fingers point to my scaphoid tubercle. This is called the finger cascade. You assess it usually through asking a patient to just make a fist, or you do wrist tenodesis if they're asleep or if they're awake to ensure all of the flexor and extensor tendons are working. How you do that is wrist flexion, which causes extension of the fingers, and wrist extension, which causes flexion of the fingers. I encourage all of you to try it on yourself. And this is one way that I assess to see if a flexor tendon is damaged before exploring. Because if the FDP insertion at the proximal aspect of the distal phalanx on any finger is completely avulsed or ripped off, as I go to extend the wrist, the finger should flex. But if one of my fingers remains extended like that, then I know for sure the flexor tendon is torn before even exploring my injury with like a couple retractors, typically some sens or some regnels. It's important to know the different types of tools that we use in the operating room and kind of at bedside in the emergency department. So the most important thing for all of you medical students is whenever you learn something new, write it down because it's gonna appear again. And if you have it written down, you can review it at a later date, and your retention will be much higher with spaced repetition of your documentation of whatever it is you learned. Clinical situations where splinting may be used is stabilization of acute fractures, sprains, strains before further evaluation or definitive operative management. Like I had an open distal tibial spiral fracture the other week, and I knew it was going to the operating room the next morning for several reasons. Number one, it was open, so it has to go to the operating room for a formal washout. Even though we did a bedside emergency department washout, you have to know the Gustillo-Anderson classification for open fractures. It's very important. Class 1 is an open fracture that's usually less than 1 centimeters. Class 2 is 1 to 10 centimeters. Class 3 is greater than 10 centimeters or a really high energy injury mechanism, something present with comminution, a gunshot wound, something like that. And then there's three classes within class 3. There's class A, which is an opening uh, essentially essentially may require like soft tissue um, interposition. Uh, Class B, which requires like a soft tissue flap. Class C, which requires a vascular flap, and then Class A is the basic one. Um, but essentially, the clinical situations when splinting may be used are all of the following, including immobilization of a suspected occult fracture, like a scaphoid fracture. But I had like a patient come in like 3 days after they told me about how they injured the web space, and as soon as I touched them dorsally, they would jump off the bed. The web space or the snuff box is made up by the first and the third dorsal compartments. It's where people used to sniff crack and cocaine off of, or maybe they still do. That's why they call it the snuff box. And it's between the APL and the EPB, which is in the first dorsal compartment. It's actually the clinical muscles isolated in the Quervain's tenosynovitis, which is analyzed with the Finkelstein test when you put the thumb in the fist and then you ulnarly deviate. Then you'll get pain over the first dorsal compartment, which is the APL and EPB, and then over the third compartment, which is the EPL. In that region there at the level of the wrist is the scaphoid bone where your snuff box, where you have tenderness there. But if whenever somebody comes in with a fracture that's a couple days out, okay, all of the swelling has resolved. Whatever it looks like right there is probably the worst it's going to look like. And I'll just put them in a cast because depending on, okay, this doesn't need surgery. We're going to treat you in a cast. We're going to see how you do. Or this for sure needs surgery. I'm going to put you in a splint. And then, because splints are way easier to take off than casts. Casts you have to cut off. There's a risk of compartment syndrome. There's a risk of getting cast burns for pediatric patients when removing them, but they hold fractures better. And in pediatric patients, we usually bivalve them, which means cut two holes in the cast as if we're taking it off, opening it up just a little bit, like a millimeter or two, and then overwrapping it with an ACE wrap to make sure that it does hold, but it at least allows for some breathability of the tissues. Splints are also used in severe soft tissue injuries requiring immobilization to allow the soft tissues to expand. Remember, compartment syndrome is when the compartment pressure is greater than 30 delta P. Delta P is the diastolic pressure minus the intercompartmental pressures, usually measured with like a striker needle that you have to insert into all of the compartments, usually within a couple centimeters of the fracture site. Um, and be familiar with all of the compartments of each limb, upper and lower, of course. Um, we had a compartment syndrome of the foot a couple weeks ago. That was a cool surgery we did. Of course, like a 9 compartment fasciotomy, opening everything up, letting the tissues breathe. And right after, his toes, which were like black and blue, regained the capillary refill and became like nice and pink again. That was pretty satisfying. But the definitive management of specific stable fracture patterns is, of course, another reason we split. But like I said, usually if it's like stable, I'll just put them in a cast, depending on how long out they are from their injury. Peripheral neuropathy requiring extremity protection. In other words, if you have a diabetic with a really bad, like diabetic foot ulcer or something like that, the board answer, the first step of management is put them in like a splint with a really well padded region to allow that area to get pressure off of it and heal well. Because a lot of people just sit on their couch or their bed all day, they'll put their heels on the same spot and develop pressure sores in that area. So putting them in a splint essentially divides that pressure into multiple areas and allows for good healing. And then partial immobilization for minor soft tissue injuries. Um, it doesn't provide as good immobilization as a cast, as I said. And then treatment of joint instability, including dislocation. Like if a patient just dislocated their radial head and had a fracture at the proximal ulna, that's called a Montesia fracture, as most of you guys should know. And of course, I'm going to splint that because it was dislocated. And then I'm going to splint it in either supination or pronation, depending on how it looks and how it's most stable to prevent it from remaining dislocated while pending surgery in the adult. But if it was a Montesia fracture in a pediatric patient, usually that can be casted, doesn't need surgery, heals up just fine. So there's different indications in different age groups and whatnot, which essentially determine the long-term and longevity of many individuals. But for splinting materials, stockinette is sometimes used, but almost like rarely. Usually we use stockinette, which is like a sock-like first layer covering that goes over. Always cut the stockinette long so you can fold it over on the ends of the cast when you do put it on. But it is the first layer to cover and protect the skin. After that, you measure your plaster and then you fold it over. That's one way to do it. There's a couple different techniques. But the most important thing for you guys to remember is for using plaster, it's 8 to 10 layers for upper extremities, 10 to 12 for lower extremities. And the most important thing is never more than 12. You're going to get asked why. The reason is because it increases the risk for thermal necrosis without increased likelihood of fracture of losing fracture reduction. So essentially, it's not any better, but it's a lot worse because it might burn the patient because it creates an exothermic reaction once dipped in the water and then molded out, and then you can cause a thermal reaction. The more layers, the hotter it gets for the patient, and they can actually get burned. Other than that, you use cotton padding underneath the plaster and above the stockinette, obviously, sometimes called web roll. And then you ace wrap your splint right after that, and then of course you have buckets of water. When I'm like when I'm like not doing a super complicated reduction, I'll put like really warm water, throw a splint on. The splint will harden up within a minute. When I have like a really complicated, really mal-reduced, like proximal both bone forearm fracture in a pediatric patient, I know that if it's more than 10 degrees malaligned, which is literally from this to this, the patient is going to need surgery. So I'm gonna cast them up, but with like really cold water to allow for a greater working time for me to essentially continue to manipulate and to reduce and to make sure that everything looks really good. Whenever reducing any type of fractures, we always use 3-point molds. We'll talk about that shortly. And then there's different types of molds on different extremities. And then very important for a medical student, all of you guys should have the Pocket Pimped book if you guys joined the SAOAO, in addition to trauma shears and pens. That's what you need on every orthopedic surgery rotation. So make sure you don't forget that stuff. So the principle for all splints: avoid wrinkles, so lay it on nice and smooth, and pressure points to prevent creating pressure sores. Once a splint has been applied, don't change the limb position to avoid splint breakdown. So essentially, what I saw once is somebody applied like a splint, like a sugar tongue splint for a distal radius fracture, and then after the distal radius fracture splint had been applied, then they reduced the fracture. Well, now there's a couple of problems. The splint, you just applied it like this. Now you grab that splint and you pushed it like that, and now there's a really big area of pressure soreness right under the volar crease of the wrist where you move the splint, because that's not the appropriate steps you have to do things. There's every step, every time you see a fracture reduction, it should be done like so. Reduce the fracture, keep it out to length, apply your splint. When you're applying a splint and then putting a reduction on, that's usually inappropriate technique. However, it can be appropriate for very, very like narrow types of indications. Like if I have like a really young kid with like a distal radius fracture, that's like in the shaft, extra articular, extra physeal, which means extra articular. These are two things you always comment on in every single x-ray you read, if it's extra articular or not, especially if it's like a distal or proximal fracture in a long bone. And then you have to talk about physeal involvement, whether it involves the physis or the growth plate, which tells you what you should tell the patients. Every patient wants to know what's their prognosis, what's their long-term risk, how are they going to do, how are they going to heal. To have all of those answers, you have to have a really good understanding of the injury, of the mechanism, of any other associated injuries, comorbidities, risk factors for non-union, such as smoking, diabetes, whatnot, other injuries like that. And then, of course, the x-ray. How does the x-ray look? How bad is the injury? Um, of course, you want the splint snug, not tight. Splints are less likely than casts to create compartment syndrome, but it's still possible if it is too tight. Always pad the bony prominences and rough edges on risk, or risk and irritation, sores, and neurologic injury. So right here, this is a calcaneal heel ulcer, probably from a diabetic with peripheral neurovascular disease or even arterial disease. And if this was well padded, we always well pad the heels. We always well pad the bilateral malleoli. And like an elbow, we'll always well pad the elbow because it's a bony prominence that doesn't have all the soft tissue of, for example, like a forearm or something. where you're not going to get much pressure soreness because it's not sitting on a bone, unlike the elbow, which is directly a bone. Um, and then no direct contact between skin and plaster fiberglass. So be very careful. Sometimes people, put the cast padding up to here, and then their plaster or fiberglass a little bit longer. Well, now every time that they move their fingers while they're in the splinter cast, because life continues, they're going to keep using it. They're going to get rubbing and wear and tear and skin breakdown and all sorts of really bad complications if you use a poor technique. And then leave fingers, toes exposed for capillary refill check. This is not always true. If you have like a really distal fracture that you're treating non-operatively, say for example of like the proximal phalanx or the middle phalanx or the distal phalanx or whatever it is, sometimes I have to put a splint all the way right past the tip of the finger and then roll it up really well because I don't want them to move even the tip of their finger. For example, if they have an avulsion of the flexor digitorum profundus that inserts at the proximal aspect of the distal phalanx, I'm going to want that inflection and I'm going to want it immobilized as far as the tips. But it is good to have like a little window or something so you can check capillary refill and make sure it's less than 2 seconds by pressing hard, looking if it's white, and then making sure it regains its color. So this is the stockinette I was referring to. Essentially, you just cut a little thumb hole, slide it on. If you cut out a stockinette this size, I would be a little bit upset. I would say make it longer. The reason for that is because, as you can see right here, the stockinette goes up to the metacarpal phalangeal joints. The splint is well applied in this step right here at the metacarpal phalangeal, at the metacarpal necks. Now, as you can see, from here to here, the stockinette got pulled over the cast. So how you put on the cast, this is for a cast, how you put on a cast is very simple. Essentially, you put on the stockinette, you cut a little thumb hole. Usually the stockinette applies, so the thumb hole doesn't have to be too big, but be careful. If you cut it too small and it's constricting the thumb, you can cause a compartment syndrome of the thumb, cutting off the blood supply. So apply the stockinette and have it extend 2 inches beyond the splinting material. I would always do a little bit more, better safe than sorry, needing a second stockinette. So having the stockinette, the splint is going to be about here in a short arm cast, which is being visualized here. So the stockinette, I like to have it right up against the elbow, about this far, so I can pull it over when I'm done and make it appear like this with a really good cuff of soft tissue, and then distally to pull it over as well. But essentially, what you do is you apply 2 to 3 layers of padding, usually about 3 layers at the distal most area to make a really good cuff of fiberglass, and then you roll. As you roll over the thumb, it's very important to ensure that your fiberglass doesn't isn't impinging on the thumb. Like today, I had a patient that was complaining that his thumb was being irritated by the cast, and the reason is because there wasn't good padding at the thumb uh, before the splint was applied, before the cast was applied. So he's moving his thumb, and it's rubbing up on the hard splint, and he could feel sharpness. Well, if he was a little bit not less with it, then he would keep rubbing. He would get a cut. He could get an infection. Really bad things could happen. So it's important to do things in a proper technique and orientation. So this is essentially how you roll up a cast. What they're showing here is indeed a splint. I was misreading it. But essentially what you do is this is web roll or cast padding showed in red for ease of visualization. And it's wrapped around circumferentially, like I said, just distal to the metacarpal necks, which would be about right there, to allow for remember your cast is all, or your splint as well, is always going to go up to the metacarpal necks, which is very important. So you have to have your splinting material, particularly your web roll and your stockinette especially, go well past that so that you can fold it over and you have a nice area of soft tissue protection there with the cast padding. And then they're showing here a volar slab, as you can see. This, most orthopedic surgeons, we wouldn't really do a volar slab for like a distal radius fracture, unless like it's like non-displaced or something, and the ER is calling me. Oftentimes they don't know how to do like a sugar tongue splint or something more complicated, like a volar slab would do just fine. And then usually you put a second roll of cast padding over the 8 to 10 sheets in an upper extremity fracture of plaster uh, to use your splint. You rewrap it and then you mold it. What they're doing right here is called an intraosseous mold. It's a mold over the volar and the dorsal aspect of the hand. Essentially, it just squeezes. But you see here, he's not squeezing with his fingers, he's squeezing with his palms, which is very important because your palms are flat. Your fingers have like little bumps to them. So if you squeeze with your fingers, you're going to have specific areas of focal pressure points that can create all sorts of complications. And if you squeeze with your palms, you're getting a good fixation without a specific point of pressure that can create a pressure sore or something like that. Um, and then what's very important, especially if you have like a sugar tongue splint, it's called 3 point fixation. So to use 3 point fixation, if this is an extremity, I'm going to use my knee, always use my knee, put the back of the elbow on it, or the front of the elbow, depending on what type of injury you have. And then for my next 2 points, I'm going to use my hand over here, and then I'm going to exaggerate this motion to essentially pull the bone in the direction that I want it. So if the bone was essentially angulated this way and I would want it angulated back, I would just pull it back like this. This is called a 3 point mold. If I wanted it the other way, all I do, same elbow, just move the hands and angle it the other way. This is a very important technique to understand when you're watching residents put it on and know how to do it as a medical student. Posterior long arm splints are very important as well. They're essentially used in upper extremity injuries for like olecranon fractures, humerus fractures, radial head and neck fractures. Depending on the type of fracture, I'll also throw in some stirrups, which are like a medial and a lateral aspect. It kind of forms a triangle at the level of the elbow to allow more immobilization and stabilization. Essentially, usually the thumb is pointing up. It has to be in neutral. What's very important is going all the way to the metacarpal heads, kind of like in that like C position. You would use like pretty big, like 5 inch, uh, 5 inch plaster if you're doing it on like a bigger hand, and like 4 inch or 3 inch if it's like a smaller hand or a pediatric patient or a really skinny uh, person. And then this is the sugar tongue splint, as I illustrated earlier. It's quite a simple application and principle. It goes from here and then all the way it wraps around the other side. And then after that, after you apply it, you can just wrap it up. You have this volar splint, which sits on the volar aspect of the hand, an ulnar gutter splint, which sits on the ulnar aspect of the hand. Like I said, depending on the injury that they have, I might have the splint go all the way to the tip of the finger. Sometimes even, I know it's not proper technique, but we do cover the fingers depending on what type of thing it is. But it is usually ideal to have the fingertip exposed so you can look at the capillary refill to ensure they don't have compartment syndrome and they have good sensation and whatnot. This ulnar gutter splint is actually like really fun to put on. I enjoy it. And even the cast technicians at Children's that had been doing it for years were very fascinated by how I put it on. Like they like enjoyed watching it because they know how to like put it on, but their molding technique isn't um, the best, I guess. But like right here, in a boxer's fracture, flex the metacarpal phalangeal joints to 90 degrees. So when doing like an ulnar gutter splint or a cast in a boxer's fracture, which is a fifth metacarpal neck fracture, and it's usually volarly angulated. How you reduce it is called the modified Joss maneuver, JAHSS. What you do after you grab these two fingers, the fourth and fifth finger, keep the interphalangeal joints extended. So extend them, bring them down, and then push pressure. So it's essentially like this and this. This is the modified Joss maneuver, which takes the volarly angulated fifth metacarpal neck fracture and dorsally angulates it, puts it in a position of anatomic orientation or alignment. When doing that, it's very important not to go too distal with your splint, because if it goes up to the metacarpal phalangeal crease, then now you can't fold it over. So it has to go up right to here, which is right there. So it's even the proximal wrist crease between the proximal and the distal wrist creases. And if they have simian syndrome or a simian crease, which is a singular wrist crease, it's usually found in Down syndrome, as you guys should know. Um, but this is called intrinsic plus position. This is how you immobilize many wrist injuries for several reasons. Number one, it decreases the risk for flexion contractures. You don't want to get them out of a splint or a cast that you put them in for 6 weeks for their bones to heal, and then their hand to be like, oh my gosh, what did I do? I can't even move their hand anymore. You essentially want to protect yourself and protect them by putting them in the right position, which is 40 degrees of wrist extension like this, 90 degrees of metacarpal phalangeal flexion, and then usually extension at the fingers, which is called intrinsic plus. What it does is it taunts up the intrinsic muscles of your hand, which include your lumbricals, which include the other muscles of your hand innervated by the ulnar nerve. You also have posterior ankle stirrup splint. Something very important to know. Does anyone know what the silver scolioid test is? You can unmute and talk. What is the silver skull test? So the silver skull test, something you have learned in med school, you guys should know, I guess, is a test that assesses for contractures of the essentially uh, it's called equinus contractures, which are contractures of the ankle and plantar flexion. You have two types of contractures. Number one is a contracture from the gastrocnemius. The gastrocnemius spans the knee, so it goes all the way. It essentially attaches to the soleus, makes the Achilles tendon, attaches to the superior aspect of the calcaneus at the calcaneal tuberosity, and then attaches all the way up against the distal femur. So it spans the knee. So when you put the position, when you put the patient prone and you have them flex the knee to 90 degrees, what it does is it essentially relaxes your gastrocnemius muscle. So it allows for your ankle to move more. So if you have an equinus contracture at like extension, and then you bring them to 90 degrees of flexion, what you're doing is you're kicking out the gastroc. You're saying, sorry, bud, you can't work right now. Because what you do is you're bringing the origin and insertion near to each other. So it's not working as well. So then now your soleus is solely at work at 90 degrees. So now you measure your equinus contracture, or essentially how plantar flexed your ankle is, to assess how much of your equinus contracture is from your gastrocnemius, and then how much of it is from your soleus. And that can help you essentially operatively plan. Do you have to release the gastrocnemius and the Achilles tendon, or would just the Achilles tendon do the trick? But this is a posterior ankle and stirrup splint. So like I said, I always ask the patients, go prone, lay on your belly, and then bring your ankle up. What that does is it brings their ankle in more dorsiflexion than plantar flexion, which is really good because I don't ever want to immobilize an ankle in plantar flexion. Different joints essentially can contract in a malreduced way in various positions. The ankle always contracts in dorsiflexion. You very rarely get in plantar flexion. I'm sorry. You very rarely get dorsiflexion contractures. You get plantar flexion contractures, which is essentially when somebody like is stepping on their toes, tippy toes. So always, whenever I reduce like ankle fractures or whenever I'm putting someone in immobilization or a splint, you got to bring up the ankle and as much dorsiflexion as you can. About 10 degrees past neutral is fine. Um, as you guys can see here, these are called stirrups. They go from a medial to lateral position. And then you also put on like a posterior slab, which goes over the posterior aspect of the ankle, the posterior aspect of the calf, all the way up to the distal aspect of the ankle, just proximal to the toes. Like I said, place the patient prone, ankle at 90 degrees. As you guys can see right there, you don't want it to be plantar flexed. And then you can place the posterior ankle splint first, followed by the stirrups, but you can really do it either way. For casting overview, we did talk about this a little bit earlier, but for casting, it's quite simple. It's circumferential, whereas a splint is slabs, so that you know the nomenclature and you use it appropriately. But traditional casts are usually used with fiberglass, although I have done them with plaster various times, usually not at the hospital here. We like to use plaster at like Children's Hospital of Detroit, where we rotate through. But the lower leg cast can be made of fiberglass with cotton lining essentially. Forearm cast made of fiberglass with cotton lining. So as you guys can see here, what you do, the only thing that they're missing here is they didn't put the stockinette on. This is like the web roll. You need good stockinette underneath that. It helps decrease burns and it helps have a really good area of essentially padding to prevent any type of skin breakdown or issues. And it essentially has more support than a splint, but it doesn't allow expansion. It's usually put in place after the splint was used. So the splint just holds the bone for a week or two. Once the bone is being held for a week or two, enough fibers, we call this like a fibrous union, enough fibers have formed in like a little capsule of healing where the bone isn't going to move too much. So then you can carefully remove the splint and reapply the cast, usually with little to no reduction required in the office. Just put it on, get a really good mold because you don't want the bone to move further. Innovations in casting, 3D printing, not beyond the subject going to be discussed today. This is called a hip spica cast. It's a very important cast. The most important thing for you all to know is that it's done for developmental hip dysplasia. In the book Pocket Pimped, it talks about risk factors for developmental hip dysplasia. There are four that you should know and are going to be tested on. I remember as a student, I got asked it, and I was, oh, so I know the answer, but this seems like a very specific question. But it is a good question, even in a joints clinic where they're like, patients are coming in, some patients had undiagnosed hip dysplasia and have complications thereof. But it's essentially when the hip doesn't sit in the socket, because the socket, which is supposed to be about 37 degrees of abduction, is more vertical than it is horizontal. So you have dysplasia, and now the hip can actually slide out, and it usually slides up like superiorly. Now the opposite problem of that is called FAI, which is more horizontal acetabulum. 37 degrees is normal. If it's greater than that, then it's called FAI, more acetabular impingement. If it's less than that, then it's called developmental dysplasia of the hip, or just hip dysplasia. What you do, as you guys can see, the baby's legs are spread apart and they're flexed. So when you hyperflex the hips beyond 90 degrees, you can create you can create a femoral nerve palsy. So essentially, you can literally like destroy their femoral nerve if you flex them up too much and they can't extend their knee anymore, because the femoral nerve innervates the anterior compartment of the thigh, which includes your quadriceps tendons that extend the knee. And if you abduct or you bring the knees out, you abduct the hip too far, you get a complication called AVN, avascular necrosis. So the head of the hip can literally die because of too much pressure when you abduct it too much. So that's just a little caveat on spica casting. So mitigating cast complication risk. Of course, anytime you do things, you want to mitigate and decrease the amount of risks that can occur. But essentially, all the same principles of splint application apply to cast application. But as the structure is more rigid, avoiding material wrinkles and padding, bony prominences is paramount to not creating ulcers. Over-aggressive molding or wrapping too tight is asking for compartment syndrome in a lawsuit. Whereas the other side of that is not molding it enough and leading to a loss of reduction. Honestly, I like put a lot of like a really good mold because the risk of compartment syndrome is very low. The risk of a malunion due to an inappropriate molding is very high. So obviously you don't want compartment syndrome, but make sure everything is well padded and then well molded thereafter. And then bivalve cuts and the dried cast, you have to wait for the cast to dry. If you cut it while it's still wet, that's going to cause a really severe exothermic reaction and burning, can allow for some expansion. So usually you cut it for example, on a forearm like short arm cast in the medial and lateral directions to allow for some expansion, to allow skin visualization and breathability as well. We kind of already talked about this, but the most important point that I wanted to talk about this was hold the body part in the desired position. It says until 10 to 15 minutes, and that's very accurate. That's uh, depending on the type of fiberglass, the temperature of the water, the patient's skin, several things like that can take less than that, or sometimes not really more than that. But neurovascular checks after the cast hardens, make sure you have good capillary refill, good sensation, especially after a really big reduction. Like once this one patient developed like an AIN palsy, like she wasn't able to have sensation over like the median nerve distributions, the first like 3.5 digits, and wasn't able to make the AOK sign, which is by the FPL, as well as the LOAF muscles of the hand. But that was because we kind of were like aggressive with her cast. So what we did is we took it off and then we kind of let it sit a little bit and then we redid it. But that also could have been because one of us was over audacious on the application of the hematoma block, which is injection of lidocaine directly into the fracture site and allows for numbing of the fracture so you can move the bones around without sedating the patient or forcing them to sit under anesthesia or something like that. But yeah, these are commonly used casts, short leg casts. They can be used for Achilles tendon ruptures, fibular fractures, tarsal, metatarsal fractures, stable ankle fractures. The reason it says stable ankle fractures is because if it's unstable, just put them in a splint. We call it an AO trauma splint. I encourage all of you to read it, which is the posterior slab in the stirrups. Um, High ankle sprains, injuries, fractures, articular, non-articular fractures of the proximal fifth metatarsal fracture, shown here. And then you can have long leg casts as well. If you have like a proximal tibial injury, that's going to be treated non-operatively. Tibial shaft, non-displaced supracondylar fracture of the femur that doesn't need surgery. You could use like a long leg cast. Short arm cast, as we can see right here. Does anyone want to read this x-ray just to preface the fracture conference we're going to have on Saturday? No volunteers within 10 seconds. I'll call on somebody.
I can try.
Sweet. Nick?
This is a 2-view AP and lateral of a skeletally immature individual demonstrating both bone fracture, mid shaft fracture, a forearm. Sorry.
Good, good. So very good, good read, Nick. Couple things to add. So always specify side. So this is likely the patient's right side, um, and then talk about the angulation. So this is how I would read it. It's a uh, distal third, both. So you would say two views of the right forearm in a skeletally immature individual, demonstrating a distal both bone forearm fracture at the distal third of the radius and a little bit more distal at the ulna. This fracture is volarly angulated, uh, volarly and laterally, volarly and medially angulated. So what that shows is, oh, and something to very important to comment on is extraphyseal. So you have to say this is an extraphyseal, extra articular fracture. If you're commenting, it is the distal third. Um, Although this can be kind of argued that it is the more middle to distal third of the radial shaft. And then this is definitely the distal third ulnar shaft. As you guys can see, this is angulated this way significantly. Like that's like 30 degrees of angulation. And then the ulna is like 50 degrees of angulation. It almost looks like it pokes out the skin too right here. But essentially, it's very important to comment on so that we know the amount of displacement and the severity of injury. And I know like right away what I'm going to treat it with. And because for pediatric both bone forearm fractures, if their child is less than 9 years old, we can accept up to 15 degrees of angulation, up to 45 degrees of rotation, and up to 1 centimeter of shortening or cortical apposition like this, 1 centimeter. Other than that, if they're less than 9 years old, it will remodel really well. For distal both bone forearm fractures in pediatric patients above 10, the non-operative tolerances where you don't need to do surgery on them is less than 10 degrees of angulation. So it's 10 instead of 15, it's a little bit less. And then less than 30 degrees of rotation. And then less than, you can't accept any cortical apposition in that regard. So very important to kind of assess and talk about radiographically. But yeah, nice read, Nick. And then this was placed here in a long arm cast for like, this is a midshaft pediatric, looks like both bone forearm fracture. But yeah, I always talk about dorsal or volar angulation. That's the most important things to talk about here. And if it was shortened or cortically opposed or something like that, that's also very important to talk about. So immobilization positioning matters. So like I said, there's safe positions that mobilize the joint. The elbow is usually 90 degrees of flexion, although for like an olecranon fracture, you never do that. It would be like more like 10 to 20. For the wrist, it would be 30 degrees of extension. For the metacarpal phalangeal area, it would be the wrist at 30 degrees of extension, metacarpal phalangeal about 70 degrees of flexion, and then interphalangeal joints and extension. And then for the hip, it's about 10 to 20 degrees of abduction, 20 to 45 degrees of flexion, 15 degrees of external rotation. And then I'm going to test your guys' listening skills. Does anyone know what happens if you hyperabduct a pediatric developmental hip dysplasia that you're treating with a spica cast? What happens if you hyperabduct them?
You can cause avascular necrosis.
Nice, Tristan. And then what happens if you hyperflex them?
Femoral nerve palsy.
Good, femoral nerve palsy. Nice. Very good. And then about 15 degrees of external rotation. And then the knee, about 15 to 30 degrees of flexion. And the ankle, you always want to neutral, but you all want to cheat dorsiflexion. So a couple of degrees of dorsiflexion. This was a very good PowerPoint put together by Jeremy. Nice job. Used all of these resources. And then I'm inviting all of you guys to my biweekly fracture conference. Next one is going to be this Saturday. I'll be sending out an email tomorrow morning for it at 5:30 p.m. You guys can join the email list. Essentially, what Nicholas did when he jumped on and read that x-ray very well. He essentially, that's what we're going to do. We're like going to go over fractures, maybe like pelvic fractures or something. If any of you have a specific interest in mind, you can let me know and we can make that happen. But other than that, you guys can scan this QR code if you would like, and then join the fracture conference on Saturday, where we talk about how to read x-rays and whatnot. It's very important for essentially assessing like your knowledge as a medical student. Like if you have a poor x-ray reads as a student, your chances at matching at any program is very low. But yeah, that's that. For this last portion, why don't all of you guys show your faces? Just want to see, and I'm interested in all of who here joined. I'm gonna snap some pics here for my PD. Just if you wanted to know, I had to leave early. I left at 6:30 p.m. instead of 5:30. Wait, something like that. Cool. All right, everyone smile. Nick, you got such a nice smile, man. You should smile more.
Yours is better.
Thank you. But yeah, guys, it was nice to have you all, and thank you for joining. I look forward to having you guys on Saturday. Any questions or anything? Sorry,
I was wondering if I ask a quick. Oh, sorry.
Yeah, what's up, Jason?
You had mentioned for the ulnar gutter splint, 90-degree flexion at the MCP, and then 40 degrees in wrist extension. And then in that last slide, for the safe immobilization, it said 70 degrees flexion with 30 degrees extension. I guess
Yeah,
is there like a
yeah, so
range?
it's like 70 to 90 degrees. The book answer is 90 degrees. That slide says 70 for whatever reason, but if you ever answer at 70, nobody's going to say you're wrong. Essentially, something I encourage you all is to go through the Student to Stud YouTube channel. It's pretty important just to learn how to read x-rays and learn different complications of different injuries and different anatomical sites and different kind of intramuscular planes that you're approaching surgically. That's like a question we love to ask like medical students, because the expectation is that you guys are in medical school, you guys just took anatomy, you guys should be, you know, intimately familiar with all of the muscles and joints and the nerves that innervate them and all that stuff. And I know many of you are osteopathic students, so what's very important is, you know, knowing all of your muscles and innervations for both like osteopathic exams and whatnot, and then for your orthopedic related things. But yeah.
Cool, thank you.
Unless there are any other questions, I'd just like to thank Dr. Haddad here. You know, we know that he's extremely busy, and so he took time out to educate us all here, and then beyond that, invited us to his fracture conference. So thank you.
Alrighty. Thanks for having me, guys. Enjoyed being with you all. See you all later. Jermaine, thanks for the invite.